Hi, good evening, everybody. Welcome to this session of question answers for valvular heart disease. That's what exactly that today's topic is. My faculty is about to join. The couple of people who are planning to join, possibly they're on their way. So I'll start. I'll get the ball rolling. To begin with, I'll request Dr. Balram. Are you there, Dr. Balram? All right. I don't think Dr. Balram is there. Dr. Vasudev Utpat.
Yes, sir. Good evening.
Dr. Vasudev Utpat, we'll start with you. And as soon as our faculty would be there, I'll hand over the mic to them so that they'll keep on asking the question.
Okay.
Tell me the most important part is what is the sequence of evaluation of mitral stenosis?
Sequence of evaluation for mitral stenosis start. Mitral stenosis, yes, sir.
We are going to ask a question. Out of that question, it is of 5 marks. And we should know like approximately how much percentage of a correct answer is there. Okay.
It starts from.
Yeah, I request you to open up your video camera also.
Okay.
Good.
Sir, it starts with 2D 2D imaging, which consists of mitral valve area, then M mode, which can give you idea of reduced DE acceleration as well as EF slope. Then it goes with the color flow, which will show the flow acceleration pattern and mosaic pattern. Then with continuous wave Doppler, we can get the gradient, of which mean gradient more than 12 gives a severity of mitral valve area. Plus with pulse wave Doppler, we can get mitral valve area by pressure half time. If it is more than 220, it gives an idea of severity. Plus, if there is a tricuspid regurgitation, it can give the idea of pulmonary pressures. If it is more than 50, it indicates a severe mitral stenosis.
Okay, reasonably a good answer. So that's great. I'll move on to Dr. Yeah, anything you want to say, Tushar? Vasudev, you want to say something more?
No, sir. No.
Okay.
Hello, sir. Dr. Balram.
Dr. Balram, okay. Oh, did not saw you. I saw you, BJ.
Yes.
I remember BJ as a Balram Jonathan Sharma, right?
Yes, sir.
Great. So Balram, tell me, if suppose you have a patient of mitral stenosis.
Yes, sir.
It is, it gives you 3 important factors, as Dr. Vasudev Utpat said. If mitral valve area by planimetry is 1.7, mitral valve area by pressure half time is 1.6, and then gradients are 11 or 12. So this kind of a discrepancy, how will you solve this kind of a discrepancy?
So in these situations, we can do a catheterization to get a better idea.
We are not going to go catheterization, you know.
Then we can do a dobutamine test, stress echo, or we can make them run on a treadmill, get their heart rate up a little bit, and kind of see if that changes, if we can get higher gradients to match the valve areas.
My gradients are already 12.
I would say just dobutamine test then, sir.
What the dobutamine is going to do that?
It's going to increase the contractility. And then if we see that the mitral valve area decreases with dobutamine, that would prove that it's true.
That is not for mitral stenosis. That's for aortic stenosis.
So we could recheck the echo, make sure we're getting the views correctly.
That's right. That correct answer is what you said in the last, not the first one.
Yes, sir.
If you have a discrepancy of gradients versus area, then the best answer is to go back and check your area by planimetry.
Yes, sir.
If the gradients are 12, area is 1.7, both by pressure half time as well as by planimetry, then you have to look back for your echo again. And apart from that, what else can give rise to higher gradients?
If you have concurrent aortic stenosis.
Aortic stenosis, no. Aortic stenosis, If you have a concurrent aortic stenosis, something different will happen.
Okay.
Hyperdynamic states. Associated MR,
Okay.
right?
Yes, sir.
So this is what your answer should be rather than doing a dobutamine. We try to avoid dobutamine in these subset of populations.
Okay.
And what we do is, like, if we have a real discrepancy between the gradients and the area, the answer is to put these people on a symptom related treadmill test.
Okay.
So look, the gradient is 7 or 6, but the area is 1.2 or 1.1. So we want to be sure about the gradients. You put the patient on a treadmill, he is going to have a higher gradients with that. Okay.
Yes, sir.
All right. So Dr. Abhijit has already joined. I'll hand over my mic to Dr. Abhijit. Dr. Abhijit, can you ask the next question to Dr. Every one of us knows Dr. Abhijit Chatterjee.
So who's the
He's
next
a consultant cardiologist based at RNTI Hospital at Kolkata.
So who's the next candidate?
Yeah, Dr. Tushar Kamal Kishore Charkha.
Yes, sir. Good evening, sir.
Yeah. Can you see my screen?
Yes, sir.
Abhijit, you have to add your screen. It is this.
Yes, sir. I'll do that. Can you see it now?
Not yet.
Now you can see it.
Yeah, we are able to see your screen, but there are no video clips as present. Yes, we saw that you're trying to open the video clips.
What do you see here in this picture? What view is this?
Abhijit, we are not able to see your screen.
You're not able to see it? Okay. Can you see it now?
No, not, yeah, it came for a second and then disappeared again.
You can see it now?
No, not yet, dear.
Oh God, it's a mess.
Is it a hostel mess or a military mess?
I'll try something else.
Okay, meanwhile, you keep on trying to open your slides and I'll keep on asking the question. Dr. Tushar, my question to you is, what are the main characteristic of severe severe mitral stenosis?
So severe mitral stenosis should have a valve area of 1 to 1.5 centimeters square by planimetry.
Okay.
The pressure half time should be 150 to 220 milliseconds. The pressure gradient should be something around 12 mm of Hg, not more than 12 mm of Hg. LA enlargement should be there, and peak pressure should be more than 30 mm of Hg, and with symptoms.
Peak pressure of what?
PAP.
Pulmonary artery. TRZ gradient of pulmonary artery pressure should be more than 30 millimeters of mercury. All right. So amongst all these parameters, on which you will rely the most?
Sir, on two parameters, mostly valve area by planimetry and mean transmitral valve gradient.
Okay. So valve area by planimetry is the most important part on which you will rely. You relies for the severity of mitral stenosis.
Yes, sir.
Good answer, Kamal. Now we move on to Dr. Tiam Baneku. Tiam, are you there?
Sir, can you see my screen now?
Not yet, Abhijit. It looks like you're trying to play directly AVI clips.
Yes, sir. You
They'll
can't.
not come unless until you put them in a PowerPoint presentation. They'll not come.
This is a PowerPoint presentation.
Yeah, you have to run a PowerPoint presentation.
Yes, this is a PowerPoint presentation.
I think you stop sharing your screen, then open it again.
Stop sharing. Okay, I'll stop sharing.
Now again, open it up.
Okay.
Yes, now we got it. Play. Make it a larger one. Great.
Is it okay
Dr.
now?
Bani Q. Kyam, are you there? Dr. Ghanshyam Motisaria.
Yes, sir.
Dr. Abhijit, you
Shyam,
can ask the question.
what view is this?
This is the short axis view at level of aorta.
Okay, fine. Now, what can you see there?
I can see aorta. I can see left atrium, right atrium, right
Right.
ventricle,
Right,
tricuspid.
outflow tract.
I see a tricuspid wall, pulmonary wall, and
Is there anything of interest that you can see in the aorta?
I can see bicuspid leaflet.
It's a functionally bicuspid valve, but
Yes.
clearly there are three cusps. The third cusp in the 12 o'clock position is very small and attenuated.
At 12 o'clock, it is right coronary cusp.
Yeah, that is small, you know.
Yes.
So the valve is opening vertically. So what kind of problems do these patients come with? What do you find on echocardiography?
I can't understand your question.
All right.
Can you repeat again?
Yeah. What do you see here? Same patient.
A long axis view.
Yes.
I see doming of the aortic wall.
So what do you think the diagnosis is?
This is
Functionally bicuspid aortic valve with
aortic stenosis.
aortic stenosis. So if you have a patient of this type, from what, I mean, what places on the chest are you going to examine the patient? What views are you going to take?
Abhijit,
First
we'll
of-
ask this question from a next person.
Sir?
We'll switch over to next person, Dr. Damodar alias Swapnil Arsekar. Damodar,
So Damodar, can you hear me?
Yes, sir.
speak loudly, Damodar.
Yes, sir.
Dr. Damodar, see, this is a patient of congenital aortic stenosis. You can see the doming of the aortic valve. Now, I want to find the aortic gradient. What are the views which can give me good gradient?
The apical 5-chamber view and the apical 4-chamber view I will go for.
Apical 5-chamber view, then apical?
Sorry, the apical 5-chamber view I will go for, and I will put the continuous wave Doppler across the aortic valve, and I will get the mean gradient and the peak velocity and the mean gradient.
No,
If the
no.
peak velocity,
I want to know the other views from which you can get a good gradient. 5-chamber view, then what else?
5-chamber view and a 3-chamber view.
3-chamber view, that is a good answer. Anything else? You move your transducer.
Yes,
to
sir.
the
I will
right
look
side
for,
of the chest.
since this is a tri-leaflet, this valve, the jet can go in any direction. So I would look for 6 windows. One is the 5-chamber view, 3-chamber view, suprasternal, right parasternal, subcostal, and
Very good.
a right anterior oblique. Where in the
Right anterior oblique. Very
in the
good.
suprasternal view, a pillow is put at the below the right shoulder, which is divided.
Can I have the next candidate, please?
Dr. Rahul Kenkan.
Yes, sir. Sorry to interrupt. I'm not able to see slides.
You can't see this? Dr. Kevin,
Yes, sir.
how are you going to assess the severity of aortic stenosis in this patient?
Sir, for severity in the 5-chamber or the 3-chamber view, we can put a continuous wave Doppler and get the AV max. If it is more than 4, then it can be considered as severe, yes. Or if the gradient is more than 40 mmHg, we can
What
classify
gradient is that? 40 mm.
mean gradient. Sir.
Mean
Aortic
gradient.
wall mean gradient.
Yeah, that is one of the rough and ready methods of assessing aortic stenosis. But other than the mean gradient, is there anything more that you are going to do by Doppler to find the severity of aortic stenosis? You found the mean gradient. it is more than 40. I tell you it is 50. Now, what else are you going to do to evaluate this patient?
Sir, we can find out the aortic valve area by continuity equation.
And how do you do that? What are the
So,
steps?
yes, sir. First, in the parasternal long axis view, we will try to take the LVOT measurement. We will then
Where do you measure the LVOT?
sir, about at the aortic annulus or 2 to 3 millimeters in LV from the aortic annulus.
3 to 10 millimeters on the LV side of the
Yes,
aortic.
sir.
That is the
Yes.
LVOT. What
Yes,
else
sir.
are you going to measure?
Sir, we will measure the LVOT VTI and the aortic valve VTI.
How do you measure the LVOT VTI? From which view? Echocardiographic view?
Sir, in the apical 5-chamber view or the 3-chamber view, we will put a pulse wave Doppler in the LVOT.
LVOT.
Yes, sir.
And the VTI. Next, what are you going to do?
Sir, then we will put a continuous wave Doppler through the aortic valve and get the aortic VTI. And then by putting it in the formula of pi r square into LVOT VTI upon aortic valve VTI.
Yeah.
Yes, sir.
You are absolutely right. But you know, we doctors are bad mathematicians. I fully know how to do the calculation, but the software of my machine does it for me. Okay. LVOT VTI multiplied by LVOT cross-sectional area is equal to aortic valve area multiplied by aortic valve VTI. How do you find the aortic valve VTI? Pulse wave or continuous wave?
Continuous wave in the apical 5-chamber view or 3-chamber views.
Fine, well done. Sir, can I have the next candidate, please?
Dr. Krishna Ansiram Yadav. Are you there, Dr. Krishna Ansiram Yadav? Dr. Yadav? Mrs. Jigna Viresh.
Yes, sir. Good evening, sir.
Good evening, Jigna. Speak little loud, you know.
Okay.
Dr. Jigna, see, this is a patient of aortic regurgitation.
Yes, sir.
And I found the aorta to be dilated. Can you see anything inside the aorta?
Inside the aorta.
You
Aneurysms?
Aneurysm, yes. There is an aneurysm.
Aneurysm, yes.
This is a special type of aneurysm.
Yes.
What type of aneurysm is this? Now, can you tell anything?
Dissection of aorta.
Dissecting
So
aneurysm.
that, yes, sir.
Can you see the flap?
Yes, sir. I can see the flap. Yes,
Can
sir.
you see
Yeah,
this one?
dissecting. Yes, sir.
So, this gives rise to
AR,
aortic regurgitation.
aortic regurgitation. Yes,
Yes.
sir.
How are you going to assess the severity of aortic regurgitation?
Severity of aortic regurgitation. If we get the jet, we measure the PHT. If it is less than 200 millisecond, then it's a severe. Then vena contracta, if we get the more than 7 mm, then diastolic flow reversal in holodiastolic is we put the CW in the descending descending aorta. If we get the more than 22 centimeter, it is severe. Then there is the jet with height. If it is more jet with height with versus LVOT ratio, if it is more than 65%, it is severe, and
Very good,
sometimes
doctor.
LV dilated.
Very good. You have said well. Sir, can I have the next candidate, please?
Thank you, sir.
Sure. May I ask you a small thing? What is this like anterior aortic root? What is this like metallic kind of a structure, Abhijit?
So there's nothing metallic in it.
Pardon?
So there's some calcification.
Calcification. Okay.
No metals here.
All right. Next patient. Next subject is Mrs. Jayanti.
Yes, sir. Good evening.
Dr. Jayanti, see, you want to measure the severity of aortic regurgitation. You know what is regurgitant fraction? Hello, can you hear me?
Yes, sir.
What is regurgitant fraction? What is regurgitant volume? Don't worry if you can't say that.
Abhijit, we have not taught them regurgitant fraction and volumes.
Okay. Sir, I'll skip that question. Dr. Jayanti, can you hear me now?
Yes, sir. Yes, sir.
Tell me how to assess the diastolic flow reversal in the aorta. Technique.
Holodiastolic flow reversal.
From which view and transducer where?
Sir, it's holodiastolic flow reversal we will measure in the suprasternal view. In a suprasternal view, we will put CW on descending aorta. And
what
if
is
it is more.
What is the finding that tells you that the aortic regurgitation is severe?
Sir, if we'll get VTI above 22, then it will be severe.
This is not VTI. We are trying to assess the diastolic flow reversal. Is it early diastolic or mid diastolic or late diastolic or pan diastolic? What makes it a severe regurgitation? Sir, have we taught them this?
Yeah, we have taught them this already.
Okay, doctor.
He's asking you a very simple question. The duration of diastolic reversal flow, like early, mid, late, or hollow?
Hollow, sir.
Hollow diastolic reversal. Very good. And see, suppose you get a patient of chronic aortic regurgitation, severe, and you put a M-mode line on the mitral valve. What are the findings that you expect on the mitral valve?
Severe aortic stenosis and mitral wall.
No, there's no stenosis. The mitral valve is normal, but you get certain findings in aortic regurgitation. What are those findings?
How does the mitral valve get affected by aortic regurgitation?
Don't you find
Well,
fluttering?
AML will become restricted.
Not really restricted. You get some fluttering of the anterior mitral leaflet. Am I right?
Sir.
Okay, thank you. Sir, can I have the next candidate, please?
Yeah, Dr. Ranjit Mohite. Ranjit, are you there?
Yes, sir.
Okay, Ranjit, go ahead.
So, Ranjit, this is a 58-year-old gentleman, and I have done his echo. So, tell me what are the findings that you get in the mitral valve?
Sir, this is apical 4-chamber view showing mitral regurgitation.
You get mitral regurgitation. You call it mild, moderate, or severe?
We have to calculate, sir, the absolute jet area.
Regurgitation. See how far the jet is extending.
Yeah,
You're not getting the full jet in one view. It is coming part by part. But then there is also calcification of the mitral valve and mitral stenosis. Am I right or wrong?
Yes, sir.
What do you find here?
There is also, sir, aortic regurgitation is there.
Okay, thank you. Sir, can I have the next candidate, please?
Okay, Dr. Dilip Bhatkar.
Yes, sir. Good evening, sir. Yes, sir. Good evening, sir.
What do you find in okay, let me get back. Can you tell me whether the aortic regurgitation is mild, moderate, or severe?
Sir, by this image, looking moderate to severe aortic regurgitation.
And how do you say that? How do you assess the severity of
Sir,
regurgitation?
we assess we assess it by vena contracta size of more than 7 mm. If it is greater than 7 mm, it is severe.
Okay, doctor, tell me something. What is the vena contracta?
Yes.
What do you mean?
Sir, vena contracta is the width of jet between the leaflets, aortic wall leaflets.
Narrowest portion of the jet.
Yes, sir. Narrowest portion of the where it originates.
Not originates. It originates on the aortic side. After crossing the valve, the narrowest part of the jet is the vena contracta. And how much of vena contracta makes it severe aortic regurgitation?
Sir, more than 7 mm.
How many mm?
7 mm. More than 7 mm.
Really, 7 is for mitral and 6 for aortic. Okay.
Okay.
What are the other parameters for measuring the severity of aortic regurgitation?
Sir, the one is that in suprasternal window we can see the holus diastolic reversal of flow.
Then
another method is we can measure the height of the jet divided by LVOT diameter. So it is if it is more than 50%, then it is we can call it as severe aortic regurgitation.
50%.
Sir, height of the jet LVOT diameter.
Is it 50% or 65%?
Yes, for severe more than 65%.
What are the findings in the left ventricle that you get in severe aortic regurgitation? Does it become small or big?
Left ventricle. No, sir, it is enlarged and septum, interventricular septum and posterior wall, it is greater than 15 mm. We can say that it is associated with LV hypertrophy also.
Sometimes we do get left ventricular hypertrophy, but there is no 15 mm figure that is given in the book. I think you.
Sir, LVOT dilation. Internal diameter will be dilated. LV internal diameter will be increased.
Sir, can I have the next slide, please?
Okay, all right. Dilip, that's fine. Dr. Dinesh Kumar Tiwari.
Yes, sir.
Dr. Tiwari.
Yes, sir.
This is a short axis view of the mitral valve.
Yes, sir.
Yeah. And what do you see?
So, the restricted opening of the mitral wall with thickening of the both AML and PML.
Tell me the diagnosis from this picture.
So this is a this could be the patient of moderate MS.
MS. So, what are the two common methods that are employed in assessing the valve area of mitral stenosis? Just names of the two methods.
So planimetry, we use the planimetry method for the assessment of the wall area, and second, sir, we use the pressure half time, and so third is the continuity-cation, which is not used as of now.
Right. Sir, can I have the next candidate, please?
Next candidate is Dr. Bhimrao Pawar. Dr. Bhimrao Pawar.
Okay, Pawar,
are you there? Dr. Rakshit Bhardwaj. Dr. Rakshit Bhardwaj.
आउटपुट काहीच नाही करे मागच्या अर्ध्या तासात.
Sir, shall I take Dr. Tushar? Is he the next candidate?
Dr. Ankan Patel.
Yes, sir.
Dr. Ankan.
Yes, sir.
See, this is a short axis view of the mitral valve.
Sir.
I want to assess the valve area by planimetry.
Sir.
What are the steps that you take to assess the valve area by planimetry? What do you do?
Sir,
Then what do you do?
sir, during diastole, sir, we will pause the video, sir.
You will do a parasternal long axis, then rotate the transducer and make it a short axis. And then what do you do?
Yes, sir. Sir, we have to pause the video during diastole, sir. Then, sir, we have to take the planimetry and measure the area, sir.
Listen, Dr. Ankar and everybody else, you have to take a short axis view, start scanning from the apex of the left ventricle, and immediately as you move up and get the opening of the mitral valve, then you stop and scroll and see the opening of the mitral valve in diastole. Did you get me?
Sir.
You know why? The mitral valve is like a cone, and you have to take the narrowest portion of the cone. Okay.
Sir.
So, how much is normal mitral valve area?
Sir, it is 2 to 3, sir. More than 2, sir.
2 to 3? No. It's not 2 to 3. It's about 4 to 6.
4.
And
Sir.
What is the mitral valve area that makes it a severe mitral stenosis?
Sir, it is less than 1 centimeter square, sir.
Dr. Gupta, sir, have you taught them 1 or 1.5?
Severe is 1 to 1.5 and very severe is less than 1.
Okay.
Sir.
So you are able to measure the mitral valve area by pressure half time?
Yes, sir.
And how do you do that? Tell me the step.
Sir, we have to take the Doppler in apical 4-chamber or 3-chamber, in 4-chamber view, sir. Then,
yes.
Sir, we have to do the Doppler, sir. Then, sir, in Doppler, sir, we have to measure the wave from the starting point and take it diagonally to the baseline, sir. And then we have to.
What is the formula that you use?
Sir, the mitral area is 220 by pressure half time, sir.
Okay, that's great. Sir, can I have the next candidate, please?
Sure, definitely. Dr. Nitin Gupta. Nitin, yes, yeah, he's there.
Dr. Nitin, can you hear me?
Yeah, yes, sir.
Dr. Nitin, I have assessed this patient and I find that the mitral valve area is 1.1. I want to assess the pulmonary artery pressure. And how do I do that? Dr. Nitin, can you hear me?
Yes, sir.
Yes. How do you assess the presence of pulmonary hypertension in a patient of mitral stenosis?
Through TR jet. Hello.
Hello, I can hear you. Go on.
Yeah, through TR jet, we will measure.
You want to measure the TR jet? Yeah, from the TR jet, what do you get? The peak pulmonary artery pressure or mean pulmonary artery pressure?
Maximum jet velocity and 4 V square, we will get pulmonary right ventricular systolic pressure.
If you trace it out, you get both the peak and mean pulmonary artery pressure. How much is normal pulmonary artery pressure?
25 is normal.
Yeah. Fine. Sir, can I have the next candidate, please?
Dr. Hiru Alamin. Dr.
Good
Hiru, are you
evening.
there?
Good evening, sir.
Good evening, Hiru.
Yeah, am I audible?
110%. You're double audible.
Okay, sir.
Dr. Hiru?
Yes, sir.
Yeah. This is a patient who has got aortic valve disease. What do you find here?
Abhijit, you have shown this case already. Move to next one.
Okay, I think it is.
This is also done. Yeah, we can see this case.
Hello, Dr. Hiru. Can you hear me?
Yes, sir.
What do you find in the aortic valve here?
Okay, sir. This is the apical 3-chamber view.
Okay, fine.
Aortic valve casts are thick and calcified.
No, Dr. Hiru, you are absolutely right. And whenever you find a severe calcification of the aortic valve, always think of severe aortic stenosis. More often than not, you will be correct. So how will you assess the severity of aortic stenosis in this patient?
Okay, sir. First of all, we will measure the mean gradient by apical 5-chamber view or at least 6 window to see the mean gradient. If the mean gradient is more than 40 or mean peak velocity is more than 4 meter per second, it will think it most likely severe aortic stenosis. Then we will measure the aortic valve area by continuity equation. If it is less than 1, then it is more likely this is severe aortic stenosis. Then another thing, if we fail to measure the aortic valve annulus, that is alveolar diameter, then we can measure the dimensionless index. If it is less than 0.25, this also indicate this is severe aortic stenosis.
Dr. Hiru, suppose you have got poor left ventricular function and if you have used the continuity equation and you have got an aortic valve area of 0.8 square centimeter, but the mean gradient is only about 30. So 30 doesn't make it severe. So what is the next investigation, echo investigation you will do to find whether it is
what about the ejection fraction of that patient?
Ejection fraction is just about 45%.
Okay, so then we will do dobutamine stress echo. If dobutamine stress echo increase reduce the valve area and increase the mean gradient, then it will indicate that it is true severe aortic stenosis. But if the valve area is not reduced and mean gradient is not improved, then it indicates it is not true severe aortic stenosis.
Excellent, you have done very well. Sir, can I have the next candidate, please?
One more question. At what dose of a low dose dobutamine you will find all these things?
Okay, sir. First, we will start to 5 microgram, I think, sir. Then increase to 5.5.
At what level you will go maximum? What do you mean by low dose dobutamine?
So it is a 5 microgram dobutamine we will start.
Your answers are correct, but if you have to do a low dose dobutamine, we will not let the heart rate go up. We want to only increase the force of cardiac contraction. And we start with 2.5 microgram, go to 5 after 3 minutes, go to 7.5 maximum, and then to 10. And then we'll not try to cross more than 10 at any cost.
Okay, sir. Thank you, sir.
Right?
Yes, sir.
Even 10, some people will also they'll be discontented with even 10 microgram because till 5 or maximum 10 is the answer, because we want to stimulate only the beta cell stimulants, not the alpha one.
Yeah, yes.
Okay.
Yes.
Dr. Sirisha, next question, Sirisha. Abhijit, you have shown this slide before also.
Sir, I think some of these slides have got deleted. There is a problem. I was having a problem with it. Okay.
Go ahead. Just move to next slide because this is shown already.
From your computer.
Sir, good evening, sir.
Good evening, Sirisha.
Sirisha.
Yes, sir.
Tell me some causes of aortic stenosis.
Some causes.
Commonest cause of aortic stenosis in adult patients.
Sclerosis, sir.
Huh? What is it? Can you repeat?
Sclerosis, sir. Sclerosed aortic valve, sir.
Sclerosed, you mean calcified aortic valve?
Yes. Then the other is rheumatic heart disease. Then there comes bicuspid aortic valve, that is in younger patients, sir.
Bicuspid aortic valve.
Yes, sir.
So, what are the changes in left ventricle that you find in a patient of severe aortic stenosis?
Left ventricular hypertrophy, sir. That is the septum and the posterior wall greater than 12 mm or 15 mm, sir.
What are the changes that you find in the left atrium?
Left atrium, not much, sir. Not directly.
Left atrial enlargement?
No, sir.
You don't get left atrial enlargement?
Maybe
Yes.
in severe
Yes,
cases.
you will.
Sir?
And how will you assess the severity of aortic stenosis?
Severity of aortic stenosis is by measuring the aortic valve area, sir. Then the
And how do you measure the aortic valve area?
continuity equations by using continuity equation.
And how do you do that?
Sir, that is by using the equations, sir. First, we have to measure the LVOT diameter, sir. Then we have to take VTI of at LVOT and VTI at aortic
You
valve.
measure the TDI of the LVOT with continuous wave or pulse wave?
LVOT is by pulse wave, sir.
LVOT is by pulse wave. And
Yes.
aortic valve?
Pulse or continuous, sir.
Continuous wave. And what is the value for severe aortic stenosis?
What is the valve area?
Valve area, which makes it severe aortic stenosis.
Less than 1, sir.
Less than 1. Very
Yes,
good.
sir.
Sir, can I have the next candidate, please?
Yeah, sure.
Thank you, sir.
Thank you.
Dr. Ganesh Tukaram Thomre. रीना एक बार डॉक्टर नंदिता को उसको कहना, देविका को लिंक भेज दो. Dr. Ganesh, are you there? Dr. Sayali Nand Kumar. Dr. Sayali Nand Kumar, are you there?
Dr. Gupta, sir, have you got a mitral regurgitation AVI clip?
We have certain clips are there. Let's finish up yours. Then Devika will join. Then last I'll pitch in.
So some of these have got deleted. That's the problem. I can't go ahead.
Don't worry about that. We'll ask them.
Got stuck.
Dr. Sumant Kumar. Dr. Sumant, are you there? Dr. Ishwar Agarwal. Dr. Ishwar. Dr. Anupa George.
Yes, sir. Good evening, sir.
Yeah, Anupa, good evening. Abhijit, go ahead.
Dr. Anupa, tell me some causes of mitral regurgitation.
Mitral regurgitation can be acute or chronic. Acute may be due ischemia.
Ischemic mitral regurgitation. You mean secondary mitral regurgitation? Secondary
mitral.
Tell me some causes of a primary mitral regurgitation.
Primary, usually the mitral valve prolapse, myxomatous degeneration, infective endocarditis, vegetations, aneurysm, rheumatic, due to radiation drugs.
Okay, fine. How will you assess the severity of mitral regurgitation?
Mitral regurgitation we can assess by the vena contracta. In severe MR, the vena contracta will be more than 0.7 centimeter, and we can assess by Mahavir ratio.
See, vena contracta is one method. What are the other methods?
We can use jet area by LA area. The jet area more than 8 centimeter square is severe, and jet area by LA area ratio more than 40% will be severe.
All right. What else?
And then Mahavir ratio. Mahavir ratio, mitral aortic velocity integral ratio.
Okay, fine. Sir, can I have the next candidate, please?
Sure, definitely. Next one is Dr. Amit Kumar.
Sir, have you taught them ERO, effective regurgitation?
No, we have not taught them ERO.
Okay. What methods have you taught them regarding MR?
MR is vena contracta, jet area versus LA area, LV dilatations, and then increased flow velocity across mitral valve, and finally mitral aortic velocity integral ratio.
Okay. Can I have the next candidate, please?
Dr. Amit, are you there? Dr. Amit Kumar? Dr. Umesh Raju?
Yes, sir.
Umesh, go ahead.
Yes, sir.
Dr. Umesh,
sir.
Tell me some causes of tricuspid regurgitation.
Tricuspid regurgitation, sir.
Yes.
Rheumatic heart disease.
Oh, yes. Rheumatic heart disease can give rise to tricuspid regurgitation.
Then usually most of them will be functional, sir.
Functional.
Functional TR.
You find functional TR in normal people?
Secondary to MS or MR.
No, Dr. Umesh, you find it in absolutely normal people. Even if I do an echocardiography of all the audience who are listening to this program, you will find some degree of tricuspid regurgitation. What are the other causes of tricuspid regurgitation?
Sir, papillary muscle dysfunction, connective tissue disorder, carcinoid syndrome, and usually secondary to lung disease like chronic cor pulmonale.
Cor pulmonale.
Yeah.
Any cause of left heart failure can give rise to tricuspid regurgitation. Then
Any cause of
infective endocarditis?
Yes, sir. Infective endocarditis, right-sided endocarditis. Sir.
Pacemaker leads?
Right-sided endocarditis.
Yes, and also pacemaker lead in the right ventricle?
Yes, sir. Yes, sir.
Sir, can I have the next candidate, please?
In fact, he has replied very well. Like, we should appreciate that he replied so many things correctly. Dr. Safila Vishal Sardesai. Safila, are you there?
Yes, sir.
Yes, Safila, speak a little louder. Abhijit,
Yes, sir. Yes, sir.
Safila, tell me, how will you assess the severity of tricuspid stenosis? You read it or you have not read it?
No, sir.
You don't know this. Don't worry. I'll ask you another question.
Yes, sir.
Tell me how you are going to assess the severity of mitral regurgitation.
So mitral regurgitation is one is the vena contracta in the parasternal
In which view will you take the vena contracta?
0.7, more than 0.7 centimeters is considered to be severe.
Typical
MR.
4-chamber, 5-chamber, 3-chamber, 2-chamber, plaques.
Parasternal long axis view, sir.
Parasternal long axis view. So that is one good method. What are the other methods?
So calculating the jet area, if it is more than 8 centimeters square, it is considered to be severe MR. Then jet area by the array area percentage, more than 40% holosystolic, it's mostly considered to be severe MR. Then other things are presence of LV enlargement and regurgitant fraction of the blood more than 50%.
I think that is difficult for you. Do you know how to calculate ERO, effective regurgitant orifice?
No, sir.
There's some technique in which you find the, aliasing.
I didn't get you, sir. Could you please repeat?
We did not teach them. We taught them the basics,
Okay. Can I have the next candidate, please?
Okay. Thank you, Safila.
Thank you, sir.
Dr. Jai Singh. Jai Singh.
Good evening, sir.
Good evening, Jai.
Yes, sir.
Okay. See, you got a patient of mitral stenosis.
Yes, sir.
Dr. Jai Singh, you are going to assess this patient for balloon valvulotomy. Tell me some.
Hello.
Hello. Hello. Can you hear me, Dr. Jai Singh?
Yes, sir.
You have got a patient of mitral stenosis.
Okay.
Your interventionist tells you that I want to take this patient up for balloon mitral valvulotomy. Tell me some of the features on echo which are contraindications for the balloon mitral valvotomy?
If sir, stenosis is subvalvular area, then it will be contraindication for.
What else?
And severe calcification.
Severe calcification. Then what else?
And if commissures also severely calcified, then
calcification is gone. What else?
And
significant regurgitation.
Regurgitation.
Significant mitral regurgitation.
Can't say sir about MR.
What is the scoring system known? Mitral valve scoring system for balloon mitral valvotomy.
Pardon, sir?
There is a scoring system for balloon mitral valvotomy. What is that system known as? I won't ask you the details, just the name.
And no, sir, I didn't know that.
Don't worry. So,
Wilkinson's.
How will you assess the severity of pulmonary hypertension in a patient of mitral stenosis?
Pulmonary hypertension. If the pulmonary artery pressure is more than 30 mmHg, then it will be severe.
And how do you know the pulmonary artery pressure? By echo.
In apical 4-chamber view, sir, we will get the TR jet. Then we will trace.
Apical 4-chamber view is very good, but you also make use of unconventional views, that you move closer to the sternum and go up by another space. So this is an unconventional view that gives you a very good view of the tricuspid regurgitation. Very good. Sir,
right.
Dr. Gupta, thank you, Dr. Jai Singh.
Thank you, sir.
Dr. Mitral Jain.
Sir, can you show some clips? My thing has got stuck here.
Okay, no issues. Clips are coming. They are on the way. Devika is joining in a couple of minutes.
Okay.
So
I've joined, sir.
Oh, wonderful, Devika. Great. So Abhijit, can I request Devika to join?
Yeah.
Thank you, Abhijit. Great. Thank you very much for being a part of this program, Abhijit. Please stay back and we'll see more questions whenever you have a time.
Thank you. Bye.
Bye.
Good evening, everybody. Good evening, sir.
Good evening, Devika. Always pleasure to see you, and now with a new heart.
Yeah, thank you, sir. Sir, can you see my slide?
Yes, I can see both of them, slides and Devika too.
Okay, sir. So
you are looking ever gorgeous as you used to.
Thank you, sir. Thanks. So
the question goes to Dr. Ganesh Tukaram Thomre. Dr. Ganesh, are you there?
Okay. Dr. Ganesh?
Dr. Mitral Jain, we have replied, Mitral.
Hello.
Okay. Dr. Namdev Limbaji Chore. Dr. Namdev. Dr. Suman Chatterjee.
Nobody is responding. Sir, what happened?
Dr. Rahul Gore.
Yes, sir. I am there.
Are you there? Great, man.
Yes, sir. Traveling, sir, but I'm getting here. Sir.
Yeah, I got your message that you're traveling. So I was little.
Okay, sir.
And it's good. Like it's great that you are there. Dr. Devika, please go ahead.
Dr. Rahul.
Yes, sir.
Yes, ma'am. Rahul.
Yes, ma'am. Yes, ma'am. I'm getting it.
So this is the the paracoronal log view of the patient. Now, describe the finding. Findings of this patient.
Rahul, may I request your colleagues to please silent for a few minutes?
Okay. I'm getting out of this. Sir, ma'am, this is the parasternal long axis view. Here with that there's a mitral in mitral wall. We see the mitral is the pathology. There's a doming of mitral wall in the left, doming of mitral in the left ventricle. Also, there is a there is enlargement of left atrium is seen, ma'am, and yes, ma'am, and there is mild pleural
Next
leakage,
time,
mild
describe the
pericarditis.
changes in mitral valve. One, you have said doming of the mitral valve. Which leaflet showing doming?
That is, ma'am, that is AML, ma'am, anterior mitral leaflet.
And what are the other two-dimensional echocardiographic findings in this particular case?
Ma'am, there is a calcification and thickening of the leaflet as there.
Okay, thickening of the leaflets,
Thickening of the leaflet at the
doming of
tips.
the anterior mitral valve leaflet, and what else?
Calcification, ma'am, little bit at the tip.
Can you see the calcification? Okay.
Little bit.
Anything else?
And enlargement of left atrium, ma'am, and there is a dilated coronary sinus below.
This is not the coronary sinus. This is descending thoracic aorta.
Okay, sorry, okay.
What about the PML? Do you see any change in the PML?
Yes, ma'am, there is not clearly seen.
You haven't seen. And what are these structures called?
Yes, ma'am.
What is this structure?
This is capillary muscle, ma'am, sideways.
And capillary muscle is far away. Regard?
Vegetation? No, I'm not getting.
What are the findings? Do you think these findings, sir?
What, ma'am?
All these findings are in the view of. Are you driving?
Yes, ma'am, I'm traveling, ma'am.
Which disease this patient is having, you think?
This and the rheumatic heart disease, ma'am. I will go for rheumatic.
Rheumatic aortic valve disease?
Rheumatic aortic valve disease.
Not mitral valve disease.
Rheumatic mitral valve disease, ma'am.
Whatever I am telling, you are repeating. You say clearly.
Hello.
You say clearly which disease is this?
Ma'am, rheumatic mitral valve disease. Rheumatic heart disease with mitral involvement.
Mitral, what do you think? It's MS or MR?
Ma'am, it is MS, ma'am, MS. Because coaptation.
I have to ask you, tell that these are the findings suggesting mitral stenosis. Okay, fine. Next question. Who will take the next question?
Next question is Dr. Shrikant Rajvilas Gote.
Okay, Dr. Gote.
Rahul, can you silent your mic? Rahul?
Okay, ma'am. Okay, sir.
Dr. Shrikant Gote.
Shrikant Gote. Dr. Gote.
Dr. Vinay Sharma. Dr. Anudeep Reddy. Dr. Karanveer. Samrat Madanik. Tamogna Das.
Good evening, sir.
Good evening, Tamogna.
Sir.
Tamogna.
Go ahead, Deep.
Ma'am.
Okay, hello Tamagna. Now your question is this. Name the method I have used to measure the mitral valve area.
Ma'am, this method is known as planimetry.
Planimetry of the mitral. Good.
Yes, ma'am.
Now, what are the precautions you need to take to reduce the error while using this method to measure the mitral valve orifice area? Tell me.
Ma'am, we should take the measurement when the heart rate is below 100. We should go in the parasternal short axis view. We should start from below the apex and then get up to the level of the papillary muscles. And as we go up, we should just stop at the level of the tips of the mitral valve.
Okay,
and
fine.
then we should include the commissures also in the measurement.
Okay. Any other settings of the instrument, the machine?
Ma'am, we can increase the gain of the machine to get a clear view.
Okay, so gain setting is another important thing. Okay, So what is the mitral valve area in this patient?
It is showing ma'am 1.4 centimeters square.
Well, so how severe is the disease?
Ma'am, it is a severe, it's a case of severe mitral stenosis.
Below 1.5. Okay.
Yes, ma'am.
Okay, fine. The next question.
Okay, next person is Dr. Durgesh Makwana.
Durgesh, Dr. Durgesh.
Yes, ma'am, I'm there.
Yeah. Comment on the mitral valve.
Ma'am, this is a short axis view. The mitral wall
Which short
appears
axis? You must say parasternal.
parasternal short axis view, ma'am.
Okay.
At the level of the tips of the leaflet, at present we are looking at, they are thickened, they are not opening up well. The area is reduced. So it is a severe MS. We need to measure the area and the pressure of time to comment on that.
Okay. Do you think this valve is suitable for balloon mitral valvuloplasty?
For suitability, we need to see many other things also.
No. There is a finding in
I
this.
think calcification at the commissures, which means a thickening can be a calcification also, which is not suitable for the balloon valvular microtomy.
Yes, commissural function. Which commissure? Which commissure is involved?
Anterior-medial,
Anterolateral.
Anterolateral, sorry. Yeah.
The commissure is calcified. The
Yes.
calcification at the commissure is a contraindication
Yes,
for
yes.
balloon mitral valvuloplasty.
Yes,
right?
ma'am. Yes, ma'am.
Okay, the next candidate.
Dr. Kevin Bora.
Dr. Bora.
Yes, sir.
Dr.
Yeah,
Kevin,
please.
speak a little louder.
Yes,
Dr.
ma'am.
Bora. Yes. So, yeah. Describe the findings. Which view? How is the color flow? What are the 2D findings? And
Yes.
how is the color flow? Describe.
Ma'am, this is a apical 4-chamber view.
Mm-hmm.
And there is a turbulent at the level of mitral
Now,
wall.
first describe the 2D finding. This is a color compare view. So
Yes.
first describe the two-dimensional findings, then go to the color flow.
Ma'am, the anterior mitral leaflet is not moving as compared to the posterior mitral leaflet.
You think so? It's rather opposite. The PML is not moving. AML is moving a bit, but PML is fixed. Anyway, so the leaflets are, they are a normal thickness or thickened?
And they are thickened.
Tell all the two-dimensional findings. Thickened. Then second point, quick, restricted.
Restricted. Yes, ma'am.
Tell you have said just now restricted motion of.
The anterior mitral leaflet.
And what about the PML?
The PML is restricted, ma'am. PML is moving well.
No, PML is fixed. AML is moving a bit. Okay, now describe the color flow.
Ma'am, there is a turbulence at the level of mitral valve. And
what does it indicate? What do you think? Which disease the patient is having?
Severe mitral stenosis.
If I say it's subvalvular, will you agree? Subvalvular mitral valve stenosis? Do you think it's subvalvular or valvar? How do you differentiate? The turbulence is starting at which level? I tell something, Dr. Bora.
At the leaflet, ma'am.
So it's a valvular stenosis. Okay, the next question for the next candidate.
Dr. Ravi Bhushan.
Dr. Ravi Bhushan.
Good evening, ma'am.
Good evening. Dr. Ravi Bhushan, describe the findings. Be precise. Tell the
Yes.
findings. Yeah.
First of all, the mitral wall leaflet seem to be thickened,
Mm-hmm.
and there is a restrictive motion of the leaflets,
Mm-hmm.
and there is a turbulent flow across the valve, mitral valve.
Okay.
Then a continuous wave has been deployed along the mitral valve, by which we have measured the mean and the peak gradients. And here we find that the mean gradient is around 18.19 mm of Hg, which signifies that this is a severe mitral stenosis. And on the right side picture, we have taken pressure of time, in which has been calculated to the area to be 0.8 centimeter square, which as the 2014 AHA criteria comes in very severe mitral stenosis.
Okay, good. So what about the LA? You missed one point. LA is?
LA looks enlarged, ma'am. LA is enlarged. Yes.
Good, good. Okay. Next candidate.
Thank you.
Dr. Chandan Mahapatra.
Dr. Chandan Mahapatra.
Yes, ma'am. Good evening.
Good evening, Mahapatra. These are the echo findings of a patient of mitral stenosis after balloon mitral valvuloplasty. Do you think it's a successful BMB?
First of all, madam, I want to address the valve is severely calcified. So it is not suitable for BMB, but it was taken for BMB.
Yeah.
And after BMB, there is a severe MR. Mostly there is a commissural tear.
Yes, yes. Good. So there is a commissural calcification. In spite of that, somebody has gone to do the BMB, and that has resulted in tear in the AML and resulting in the severe
MR.
So it was full of complications.
It was a failed BMB.
Yeah. Okay. Next candidate.
Dr. Yogesh Namdev Patel.
Good evening, ma'am.
Good evening.
Good evening, madam.
Good evening. Describe the echo findings of this patient.
Okay. Yes, ma'am. This is like a apical 4-chamber view. The mitral wall leaflets are thickened. The AML looks to be doming. Also, PML is also moving along with that. There is a left atrium is enlarged, and there is a mass which is not so homogeneous. I mean, in variegated appearance in between, and it appears to be arising from interatrial septum, probably atrial myxoma. It looks like, I mean, because the rhythm. Sorry, madam. It can be a clot also, because the ECG is showing atrial fibrillation in the picture. So.
What about the mitral valve?
Mitral valve is, madam, doming
So what do you
it
think?
looks like mitral stenosis due to rheumatic heart disease, probably.
Okay, so then why did you utter myxoma?
No, sorry, madam. Because the mass is not looking like homogeneously like a clot. I mean, because there are some darkish shadows in between that thing. So that's why I thought that must be something different. So that's why I said. But looking at the ECG, it looks like atrial fibrillation. So probably
I
chances
have
of.
to answer all the findings with single pathology initially. If you cannot,
madam.
you can go for the second. So it's
Okay,
a case of mitral valve stenosis, which is rheumatic in origin.
Yeah.
Enlarged LA, patient is in atrial fibrillation.
Fibrillation.
And large
Clot, LA clot, basically.
complication of
Mitral.
next candidate.
Yeah, one more point is you should not say dark shadow. You should say hypoechoic shadow.
Yes. Okay, sir. Thank you. Thank you, sir.
Dr. Majrul Islam.
Dr. Majrul.
Good evening, ma'am.
Good evening. So you answer this question. Which important two-dimensional feature I am trying to assess in this long-standing case of mitral valve disease, rheumatic mitral valve disease? What is the typical finding in this long-standing case of mitral valve disease, rheumatic mitral valve disease?
Ma'am,
Which view is this?
Ma'am, parasternal long axis view.
Right.
LA is hugely dilated, ma'am.
Okay. So what do you say this LA is described as?
Giant LA.
Giant LA.
Good.
So yeah, very good, very good. What is the length here? I have measured.
Yes, length is 10.2 centimeter, ma'am.
So a length of 10.2 centimeter.
It is giant LA, ma'am.
Giant LA. So yes, good, very good. You see the LA, it's huge.
Yes, ma'am, hugely dilated.
Giant LA. Thank you. Next question. Next candidate.
Dr. Nida Farheen. Dr. Nida Farheen, are you there?
Yes, sir.
Yeah, Dr. Farheen, this is for you. Describe the findings in this patient. Both
ma'am,
color flow.
Ma'am, that is a caudal rupture at PML, which gives to the significant MR.
Anything else other than caudal rupture? Caudal rupture is very obvious. Well, it's good. You have picked up the finding, the most obvious finding. What else?
Dilated LA, ma'am, and
what about the mitral valve leaflets?
coaptation defect, ma'am. Yeah, thickened tip of the AML.
Do you think it's tip of the AML or the entire?
Entire AML is thickened.
Yeah, don't repeat what I am telling. You should pick up the finding. Thickened leaflet. Yes. Then tell.
One more important, very important thing.
Yeah, very important finding. How is the PML? It's fixed, right?
It's fixed. RS, okay.
And what
PML is fixed, yeah.
And AML?
PML is fixed. AML is doming, sir. Sorry, RSD with caudal rupture.
You can't appreciate the doming here because the valve has very short. So what is another problem Sari is asking to know? Tell. It's not only the caudal rupture which is a sign of MR. Another finding indicating the presence of MR. Even if I look at the 2D picture, I can say yes, there is.
Yeah, I'm not.
Okay, we'll give you a hint. AML.
Okay, sir, I think.
Vedika, you can tell her what's there.
Yeah, there is a coaptation failure. Can you
yes,
see?
Ma'am, I told that defect, coaptation defect. Before only I told you.
Okay.
Yes, coaptation defect is there.
Non-coaptation, fair enough.
Because annular dilatation, there is a coaptation defect.
Okay, fine. Thank you. Next candidate.
Nida, tell me, like, are you going to analyze for its severity? What kind of a valve regurgitation this is? Can we go back? Yeah. Tell me what is the severity of this lesion?
Severity of this lesion.
Yeah. Once you see this kind of a slide, so are you going to assess its severity or not?
Sir, this is clear picture of severe MR, sir.
So, very true. If you happen to see this kind of a picture, then you don't have to assess its severity. Straightway go for valve repair.
Straightly caudal rupture is urgency to replace it.
Great, Devika, go ahead. She has done a very good job.
Yeah. One more question. Which primary disease this valve is having, other than the caudal rupture?
Ma'am, as PML is fixed, I will say it is a rheumatic affection.
Yes, it's rheumatic. Okay. Next candidate.
Great, Nida. Good job done.
Good.
Sai Prasad.
Very good.
Dr. Sai Prasad.
Yes, sir.
Sai Prasad, what is the cause of MR in this case?
Cause of MR. It looks like rheumatic, madam.
Why?
Where is the trauma, man?
Because the last case was rheumatic.
Not like that.
No. Then tell. What are the findings you think it's favoring the diagnosis.
Just concentrate on a black and white film.
Yes.
Forget about MR.
First 2D. Look
First
at the
2D is it seems to be a single leaflet there, madam. There's no PML there.
right. What is this structure? This is PML. Here is the AML. Here is the PML.
The AML is thickened.
This is a zoomed picture, so that is why you are finding it thickened. It's not thickened so much. There is a typical finding which is causing. How is the MR?
How is the
MR?
Mitral regurgitation, MR jet. Can you comment on the mitral regurgitation jet now?
Mitral regurgitation is severe, madam.
Okay, what is the direction of the MR jet?
It's eccentric.
Why? Eccentric. Which direction? Anterior or posterior?
It is posterior, madam.
Oh man, it's not
Sai
posterior.
Prasad, you are talking of Calcutta, Mumbai, Chennai, Trivandrum. Look at the 2D film, look at the MR jet, and if you say that is posterior, is amazing. You're not doing anything. Believe my words, you have not done anything in last 3 to 4 classes.
Okay.
This is a classical PML prolapse on flail leaflet producing an eccentric jet which is wrapping behind the AML.
Okay.
This is myxomatous. If you do like this, you're not reading at all, man. I can tell you, I can assure you.
Picture is so clear. It's anteriorly directed jet of MR.
I not read this flail MR, madam.
So it's all right, but why did you say it's posteriorly directed? That is it's a big mistake. You must be able to, the moment you are able to say that it's anteriorly directed jet, you will immediately find out the cause in the PML. You see, if the pathology is in the PML, the direction of the jet in an eccentric jet, it's anteriorly directed. If the problem is in the AML, it will be posteriorly directed. So it's a single valve disease, valve leaflet disease. It's only the PML which is diseased, and there is a caudal rupture, and it has caused the PML to be flailed, and that has resulted in anteriorly directed jet of severe MR. Okay, next candidate.
Dr. Manu Kapil. Dr. Manu Kapil.
Dr. Manu Kapil.
Dr. Clay from Tanzania. Clay, are you there? Dr. Tiam Banikyu. Tiam. Dr. Krishna Avatar. Krishna Ansiram Yadav. Dr. Rakshit Bhardwaj. Dr. Ganesh Tukaram Thomre. Dr. Sayali Nand Kumar Bangre. Sumant Kumar. Ishwar Agarwal. Amit Kumar Potolwar. Mitul Jain. Mitul, are you there? Namdev Limbarao Chaure. Suman Chatterjee. Anchala Singh. Shrikant Rajvilas Gote. Vinay Sharma. Anudeep Reddy Avali. Karan Veer. And again Dr. Manu Kapil as well as Dr. Clay Tanzania. All right, we go back to Dr. Balram now. Dr. Balram.
Yes, sir.
Go ahead, Balram.
Yeah.
Hello, Dr. Balram.
Hello.
Yeah. See, this is parasternal long axis view. First, I have shown you two-dimensional picture, then with the color flow. Now, you look at the picture, first at the 2D, then look at the color flow. and tell me the cause of mitral regurgitation in this particular patient.
All right. So looking at the 2D, it looks like the left atrium is enlarged. I'm seeing maybe decreased movement of the posterior mitral valve. It looks maybe like a little doming, like hockey stick of the anterior mitral valve, and also paradoxical movement of the posterior mitral valve. It's going anterior. I'm trying to see if there's spontaneous contrast echo, but I'm not really sure if
That
that's.
is due to increased gain, you see. It is a bit bright. So that is giving the...
Dr. Balram, there will not be any spontaneous echo contrast if this much of a severity of MR is present.
Exactly.
Oh, okay, gotcha.
We should not, whatever you see, even if you see, you cannot comment on this because MR will not let the blood to have a stasis.
Exactly.
Yes, sir.
Something very specific she is trying to show you.
Exactly. And we have already discussed it.
Yes.
Tell us.
It's only reverse.
On the reverse. I'm not sure. I mean, I was looking at the left atrium. It looks irregular in its size.
Look at the closure of the mitral valve leaflets. Are you happy with the closure?
It seems like it's not completely
Flail
closed.
segment.
Flail? Where is the flail segment? Are the leaflets coapting normally? Closing normally?
I'm not sure, ma'am.
Why are you not sure?
Devika, you can show him that's not non-coaptation with AML being used.
See, the valve leaflets are not closing at all. PML is fixed. AML is moving up and down a bit, but then it's not been able to close the mitral valve properly. Look at the closure. Look at the look here. See, the valve leaflets are closed now, but there is a gap.
Yes.
They are not coapting, and that malcoaptation has resulted in severe MR. And it is which disease do you think this patient is having? What is the cause of MR?
Well, I was looking at the doming, so I was thinking rheumatic heart disease.
Yeah, you should say confidently that it's a rheumatic mitral valve regurgitation, thickened leaflets, fixed PML, malcoaptation, all are findings of rheumatic mitral regurgitation. Okay, the next candidate.
Dr. Utpat, Vasudeva
Yes, sir.
Umakant Utpat.
Yes, sir.
Dr. Utpal, tell me the cause of MR in this particular case. I'm showing you.
It's difficult for them.
It's difficult, sir. So I'll skip.
No, don't skip. Continue. But it's not all difficult. But if they are intelligent, they'll pick it up.
Okay, sir.
Is it the cleft in the posterior mitral leaflet, sir?
What? What did you say? I can get you.
Is it the cleft in the posterior mitral leaflet?
Cleft? No, I can't see the cleft. Look at the four-chamber view.
Correction.
How are the leaflets?
They are thickened, calcified, myxomatous kind of.
Okay, myxomatous, good. Then?
And
they are not calcified. If you look at the myocardial thickness, density, echodensity, and here it's same. There is no calcification. It's myxomatous, I agree.
Myxomatous.
And what else? I'll stop this. Just concentrate on this. Can you see something?
Very beautiful presentation. Very beautiful. Jigna will give you just give us a time. We'll come back to you.
Okay, sir. I'll go to the next.
No, don't go back. Don't go to next question. Jigna, you want to say something?
Is prolapse?
Yes.
Ghanshyam, try.
Yes.
Now, this is a very classical presentation of, look at this very carefully. Look at the two jets very carefully in plaques window.
It is prolapse.
Prolapse of?
Prolapse of EML.
Sir, actually, it is mostly the prolapse due to the caudae of rupture, mostly the ischemic MR.
No, it's not a ischemic MR, man. This is classically a myxomatous valve with a prolapse. And if you have
both the leaflets.
Both the leaflets, and you look at very carefully in the second picture. Initially, you will find an eccentric jet behind AML, then another eccentric jet behind the PML order. Look at very carefully. She has shown you an excellent picture, you know.
Two jets.
Two jets are there.
So due to the pathology of the AML, there is a posteriorly directed jet of the MR, and due to the prolapse of the PML, there is an anteriorly directed jet of MR. So it's a case.
Just concentrate on the second picture. Look with, can we freeze it up, Devika?
Yes, sir, sure.
So show them like this is excellent way of presentation. This particular slide is.
This is the posteriorly directed jet. It's coming on the posterior aspect of the left atrium, and there. You see, this is one jet, and this is another jet. Can you see?
Yes,
yes,
ma'am.
yes, ma'am.
And
Sir?
majority of time, yeah, this is beautiful. Majority of time they are myxomatous.
So I'll go to the next question then.
Yes, sure, definitely. Next question goes to Dr. Tushar. Dr. Tushar, are you there?
Yes, sir.
Yeah, Dr. Tushar, comment on the pattern of spectral envelopes of mitral regurgitation in these two different patients. This is an apical 4-chamber view. I have done the continuous wave Doppler across the mitral valve where there was MR. This is the picture of patient A, and this is the picture of the patient B. Now, comment on the pattern.
Ma'am, the pattern of MR jet in patient A is asymmetrical and it is spent, while in patient B it is symmetrical and is dense, sorry.
Symmetrical. Okay. You mean to say the density?
Yes, it is
Okay.
dense.
It's a faint signal and this is a dense signal.
Yes, ma'am.
What else?
This is a very specific finding in this MR jet. Very specific. If you pick it up, that'll be excellent.
Exactly. The first point he has said, we are happy with that. And anything else?
Another very important finding.
Very important. Look at the shape of the
Dagger shape.
No, this is not dagger.
This is not dagger. Dagger is like these, you know, dagger will be like this.
Rapid acceleration or deceleration.
Yes, who's Dr. Ghansham? Who's saying this rapid acceleration and deceleration?
Sir, in figure 8, it is a mild tongue emission.
Short acceleration time.
One at a time, please.
Figure A shows mild type of error. Figure B shows severe MR because of symmetry.
Severe MR, who said? Say clearly.
Ma'am, in figure A, it is a mild MR because it is symmetrical. Figure B, it is a severe type of MR because the figure is asymmetrical. The pattern is asymmetrical.
No. Someone was telling.
The acceleration time is short.
Yes.
And acceleration time is longer.
Who is this?
Ghansham.
Ghansham.
Yes.
Okay, Ghansham, tell me.
The acceleration time is shorter than deceleration time. So filling of left atrium is rapidly.
Yes. Early pickup.
Yes.
Early pickup. And look, in contrast, this patient, The MR, look at the acceleration. It's a slow, round-shaped MR jet and a faint signal. And the shape is very important. It's a round shape. This is mild, whereas this is
severe.
Severe because there is an early peak. Sir?
Yes, true.
Yeah.
The first figure shows tongue-shaped MR and second shows classically rapid acceleration and slow deceleration.
Exactly.
And even if the gradients are low in the second film, it's only 4, but still it classifies to a severe mitral regurgitation.
Severe, it's severe. So I'll move to the next question.
Yes, please go ahead. Dr. Ghansham, you have already replied. Excellent, Ghansham. God bless you. You're doing good.
Good.
Thank you, sir.
So this question is for the next candidate. Who will answer the sir?
Dr.
Ghansham?
Damodar Swapnil.
Okay, Damodar. Dr. Damodar?
Yes, ma'am.
Yeah. See, this is to describe this view and as well as the MR jet, which are the components of the MR jet visible here. You need to know the components of the mitral regurgitation jet also. So tell me.
Ma'am, the MR jet starts with the vena contracta, which is at the narrowest portion, narrowest orifice point between the two leaflets. Then it moves in body.
Before the vena contracta, is there anything else? How many components of the MR jet we look? 3. Who is answering?
Dr. Umesh.
Dr. Ramesh. Okay.
Umesh.
Umesh. Okay. What are the components?
One is first part is flow convergence, madam.
Can you see?
Second, yes, madam. Just after the leaflet. Second is the narrowest part.
Where is the flow convergence? It's in the LA or in the LV or at the LV. Okay, flow convergence. Then
in between the leaflet is the vena contracta, madam. Neck.
And then the third
and recurrent volume. It is in the LA.
Okay, jet area. Okay, these are the 3 components. Good.
Excellent. Very good.
Excellent. Very good. Very good. So the next question, sir.
It goes to Jigna Viresh. Jigna, are you there?
We have already answered part of the question, I mean, partly. So, Jignesh?
Jigna and Jayanti, are you there? Any one of you? Okay. Dr. Ranjit Shankar Mohite.
Yes, sir. More than 7 millimeter.
Oh, he has answered the second part.
Yeah, already he has answered.
Yeah. 7 and more. Okay, from 7 or more.
7 millimeter, kilometer, centimeter.
Millimeter, sir.
Okay.
Okay, fine. So I'll move to the next question.
Okay, Jigna is here. Jigna, now it's for you.
Jigna? Dr. Jigna?
So Jigna's presence is there. She says, I'm here, but we can't listen to you, Jigna. Unmute yourself and speak a little bit. Jayanti is also here. Jayanti?
Am I audible, sir?
Yeah, Jayanti, tell us.
Hello. Yes, sir.
What is this?
This is doming of aortic wall, calcification of aortic wall.
Okay, describe this view and tell us the finding.
This is short axis view at aortic wall level, and the aortic leaflets are bicuspid.
Okay.
And calcified, and non-coronary cusp is doming in another view, this right side view.
So this is a case of bicuspid aortic valve. You have answered
Yes.
the first question, right? Now, tell me, how common is this condition? Commonly?
Not commonly, but sometimes we see bicuspid aortic wall. Not very commonly we see.
Well, it is the most common acyanotic congenital heart disease. Do you know that? You don't know.
No.
Yeah, this is the commonest acyanotic congenital heart disease in adult. You will get to see many cases. Now, tell me, the same patient, bicuspid aortic valve, what is a finding here? We should
Aorta is dilated.
Okay.
And leaflets are thickened, doming, and restricted movement.
Okay. What do you think this patient will have? This bicuspid valve, bicuspid aortic valve, is it normally functioning?
No, it is restricted.
So it will have some stenosis.
Yes. Yes.
Okay. Okay. Good.
Good. Very good.
Very good.
Thank you, ma'am.
Okay. Okay. The next person.
Next person is Dr. Dilip Pandit Bhatkar. Dilip
Bhatkar.
Dinesh Tiwari.
Yes, sir.
Dinesh, tell us this entity.
So this is parasternal substructure fluid at aortic level, and the aortic wall is tricuspid.
Aortic valve is bicuspid. Tricuspid.
Look, it has to be bicuspid, tricuspid. If it's bicuspid and tricuspid, while she show you.
I have shown the bicuspid.
Look carefully.
Very carefully and count the number of curves.
It's a very rare phenomenon. Very rare phenomenon.
Huh?
Quadri.
Quadricus.
Yes, sir.
Who said quadri?
Quadricus.
Rajur.
Yes, sir.
Good, Ramesh. Good pickup.
Good. It's a quadricuspid aortic valve. It's very, is it very common?
No.
Rare.
Very rare.
Very rare.
Yeah, very rare. It's 0.04% of the cases. It's very uncommon. Now, what is its commonest complication of this quadricuspid aortic valve? Is it AS
AR
or AR?
AR.
Somebody is AS, somebody is telling AR.
Ma'am, it's both AS and AR.
Look, this is the commonest
Devika, either AS or AR. That's what I'm saying.
Yeah.
So it is commonly we see AR in this.
AR in these subjects.
Yes.
In fact, that is very clearly seen in your first slide itself. You know, it's not closing at all.
There is a malcoaptation.
Yes, it is showing very clearly out there.
So I'll move to the next question, sir.
Beautiful slide, Devika. I must appreciate your slide.
Thanks.
Go ahead, next clip.
Yeah. Okay, we'll take this question.
Dr. Bhimrao Pawar. Bhimrao, are you there? Dr. Pawar? Ankan Patel?
Yes, sir.
Go ahead, Ankan.
Dr.
Sir.
Patel?
Sir, ma'am.
Yeah, this is the echo of a patient of aortic stenosis, aortic valve stenosis. As you can see here, it's hardly opening. With the and look at the LV, it's the ejection fraction is 34%. And from the apical 5-chamber view, I get a gradient of 54 by 34 millimeter of mercury across the aortic valve. So in that case, this 34 millimeter of mercury indicates what? Moderate aortic, right?
Ma'am, yes, ma'am. It indicates the moderate AS, but ma'am, this is a case of severe aortic stenosis, ma'am. As ma'am, the ejection fraction is also very, very low.
So which method are you going to use to comment on the severity of aortic stenosis?
Sorry, ma'am.
Flow, low gradient.
Ma'am, low flow.
Okay, fine. Low flow, low gradient, you said. Now, what will be your next step to comment on the aortic valve, severity of the aortic valve stenosis? You can't say only from the picture.
Robute stress echo.
Stress before that.
Aortic wall area.
Who answered this question? Who is this?
Dr. Ramesh Rajur, madam.
Okay, Dr. Ramesh, how do you do that?
By continuity equation.
Okay, tell me the steps.
We have to measure LVOT diameter by Planck's view, madam. LVOT VTI by pulse wave Doppler, and aortic wall VTI by continuity wave Doppler.
From which view? Aortic valve VTI? Again from the fact paper. Okay, here. Okay, very good, very good. Now, what are the precautions you are going to take while measuring the LVOT diameter?
Ma'am, it could be measured in
Let
pistol,
Ramesh
ma'am.
answer this question. Let Ramesh answer this question because he answered partly. So let him finish. Ramesh?
Madam, it should be done in mid-systolic, madam.
Okay.
And the caliper, we have to place 2 to 5 millimeter inside the LVOT from insertion of aortic wall leaflet into the intraventricular septum and anterior mitral wall leaflet, madam. One hinge point to another hinge point.
Okay, it's not the hinge point. Hinge point we take at the when we measure the annulus. It is a bit on the LV side within 1 centimeter. Then before that, what do you do? You need to zoom the view.
Planck's view, zoom the
view. Because you remember that this LVOT area gets squared in the formula. So even if there is a difference of a fraction of millimeter, it will get squared, and there is a chance of error in your calculation. So always remember to zoom so that you can see the LVOT diameter very carefully, and then you take the measurement. Good, Ramesh, well done.
Thank you.
Okay, next.
All right, next one is Dr. Nitin Gupta.
Dr. Nitin.
Dr. Hiru Alamin.
Yes, sir.
Yes, Hiru, go
Am
ahead.
I audible?
Yes.
More than audible.
Dr. Hiru.
Okay, thank you. Yeah.
Sir, you said Hiralal.
Hiru Alamin.
Hiru. Dr. Hiru, this is, tell me.
Okay.
What
Okay. This is the parasternal long axis view and color flow showing regurgitation jet to the LV. The most likely this is a severe aortic regurgitation with aorta is dilated, and there is also mitral regurgitation also present.
Okay, now try to answer these questions.
Okay, where do you measure aortic regurgitation?
No, vena contracta for aortic regurgitation. Now I see
Okay.
that it is to here. So where do you measure?
The vena contracta is the narrowest portion of the regurgitation. So we will measure it in between 2 cusps of the aortic valve.
Is it here?
The narrowest portion.
Is it here? Or here?
Yeah.
Where?
No, in between 2 cusps of the aortic valve, ma'am. The narrowest portion.
Okay, good. This is the area, right?
Yeah.
Yeah, on the LVOT side, not inside the OT.
Yeah.
On the LVOT side.
Yeah.
Okay, good. Now, what is the cutoff value for severe AR? Measurement of vena contracta.
The cut of the value of the severe AR is 0.6 millimeter or more.
0.6 millimeter.
No, 0.6 centimeter or 6 millimeter or more.
Okay. Okay, good. Sir, I think he has answered.
Very well. Devika, is it dissection of aorta?
Yes, sir.
This flap is seen over there.
I think there is a flap is present.
Yes, sir. Yes.
Whenever you see two aortic valve, always think of dissection of aorta. So this is one valve which she showed you, another valve towards aorta.
Yeah.
Yeah. Thank you, sir.
Excellent slide, Devika. Go ahead, next.
Yeah, sir. Again, a similar question which I asked for MR. I'm repeating this for AR. Who is going to take this?
Sirisha.
Sirisha?
Sir, good evening, ma'am.
Good evening. Comment on the spectral envelopes of aortic regurgitation in these two different patients, patient A, patient B.
So patient B, the spectral envelope is dense, ma'am. So probably patient B will have more severe AR, ma'am, compared to patient A.
And in patient A, how is the spectral pattern?
It is not homogeneous, ma'am. I mean, it is dense nearer to the base, and as we go up, it's become less dense.
Yeah, it's faint. Okay.
Yes, ma'am.
And anything else? Done the measurement. Can you see?
Pressure half time, ma'am. PHT.
In patient A, it's 508. In patient B,
it is 201.
So what do you think?
B is more severe, ma'am.
When do we say severe for pressure uptime?
I exactly don't know the value, cutoff point.
Less than 200.
Huh?
Less
than 200.
200. In some books, it's written 225. Sir, it's 225, isn't it, sir?
Yes, is approximately 200, like some 220, 240,
yeah.
Like many variables are there, but she's right. This one is very severe, severe aortic regurgitation, other is mild aortic regurgitation.
Okay.
Sirisha,
Next,
good job done.
Thank you.
Good, Manisha. Next question.
Next question goes to Dr. Anupa George.
Dr. Anupa.
Dr. Anupa, are you there? No, she has left already. Dr. Safaila Vishal Sardesai. Mitul Jain. Then Rahul Ganesh Gore. Jai Singh. Jai Singh, are you there?
Yes, sir, I am here, sir. Hello.
Jai Singh, go ahead, tell us what's there.
Hi, Jai Singh.
Yes, hello, good evening, ma'am.
Good evening. So this is the color flow across the arch of the aorta. This is the color M mode across the descending thoracic aorta, and this is the pulse wave Doppler.
Ma'am, this is the flow reversal at descending aorta.
So how severe?
And followed, we will measure the VTI at.
Now tell me, you said flow reversal in the descending thoracic aorta. Which color is the is for flow reversal? Why do you say that it's a flow reversal?
Because, ma'am, blood is going reverse to LV in diastole, which is showing red color because it's going towards the point.
Yes. Okay. Fine. Now describe the color M mode. What do you see in the color M mode? I have kept the cursor at the descending thoracic aorta and I've done the color rainbow. Can you describe it? Anybody?
Well,
early diastole.
Yes, ma'am. Hollow diastolic flow
Hollow
reversal.
diastolic flow reversal.
Hollow diastolic flow reversal. Very good. Which color is indicating hollow diastolic flow reversal? Which color?
Red.
Red color, ma'am.
The hollow diastolic. And what it is?
This is the we are measuring, ma'am.
I have kept the
TW.
sample here and I have done the pulse wave Doppler. Now describe it. The one below this yellow line indicates what, and one above the baseline indicates what? Tell me.
Above the baseline, ma'am, is AR jet.
Flow reversal, not the air jet. The flow reversal.
Okay.
Flow reversal. And because I have kept the sample volume here, it's not the air. We are looking at the air, the flow reversal in the descending thoracic aorta. So this is the flow reversal. It's hollow diastolic flow reversal. Okay, good. Well done. Next question.
Very good job done.
Yeah. Next question.
Dr. Tamogna Das.
Yes, sir. Yes, ma'am.
Yeah. Comment on the two-dimensional findings of tricuspid valve as well as the color flow pattern across the tricuspid valve. First, look at the 2D picture. I will stop this. No.
Yes, ma'am. The motion of both the valves of the tricuspid valve are not equal, and they are not coacting.
Not equal, and they are not coacting.
Yes, ma'am.
What type of description it is? Like, what disease do you think?
This is a case of tricuspid stenosis.
Okay, so in stenosis, what are the findings you see usually in mitral valve, in tricuspid valve?
Ma'am, there will be thickening. There might be thickening of the valves.
Yes,
Then there might be doming of the valves.
Yes,
Then
doming?
Yes, ma'am. The doming.
Yes.
Yeah, it is because of the ma'am. The tip will be away, and there will be convexity facing towards the ventricle.
Exactly. So
Ma'am,
yes. Why don't you tell these terms? Why don't you use these terms? Thickened leaflets. There is diastolic doming of the leaflets, and
yes,
small
and,
area of calcification.
Yes, ma'am.
And how is the opening? Do you think it's normal?
No, ma'am. It's reduced.
Reduced. Now look at the color flow. What do you think?
It shows a very nice stenotic jet with mosaic during systole.
What's the?
Across the tricuspid valve during diastole, ma'am.
And anything else? Is there any tricuspid valve regurgitation?
Yes, ma'am. There is a very slight regurgitation during early systole.
Okay. So what do you think? It's congenital, carcinoid. What is the cause of tricuspid valve stenosis in this particular case?
This might be most likely due to rheumatic heart disease.
Why are you telling rheumatic?
Ma'am, because there is decreased motion of the posterior tricuspid valve leaflet, one of the valve leaflets, and
movement even in the carcinoid syndrome. But the most importantly, there are doming.
Yes.
And look at the mitral valve.
Yes, ma'am. Mitral valve is also very much thickened and calcified.
So it's rheumatic.
Rheumatic, yeah.
Disease. Okay, good. Well
If
done.
there is no mitral involvement, then think of a carcinoids.
Yeah.
Yes, yes, sir.
Okay, next one. Dr. Durgesh Makwana.
Dr. Durgesh?
Yes, sir. Yes, sir.
Yes.
Yes, madam.
Severity of mitral tricuspid stenosis.
same patient. I have done the CW Doppler, and
Yes,
I
ma'am.
find a mean gradient of 4.48 millimeter of mercury. So
Yes, ma'am.
what is your comment on this?
Mean gradient, if it is more than, pardon, ma'am?
Tell.
Yeah, if the mean gradient is more than 5 to 10, we call it to be a severe TS, tricuspid stenosis. But now it is 4.48, so moderate tricuspid stenosis.
Yeah, it's almost, you see, it's.
Yes, ma'am.
You need to be concerned when the gradient is more than 2 millimeter of mercury.
Yes, ma'am. Yes, ma'am.
When you are taking care of the mitral valve disease, you need to take care of the tricuspid valve disease.
Tricuspid. Yes, ma'am.
Next question. We are almost finishing.
Kevin Bora.
Yeah. Dr. Bora?
Yes, ma'am.
Yeah. This particular patient had balloon mitral valvotomy a year back for severe mitral stenosis, rheumatic mitral stenosis. Now the patient has come back with shortness of breath. And when I did the echocardiography, this is my finding. Now comment on the findings.
Ma'am, there is severe MR.
Look carefully, man. Where is severe MR?
Okay, which chamber is this?
And this is left atrium.
This is
Left atrium.
and this? Which chamber is this?
Sorry, ma'am. The right one is left atrium and the left one is right atrium.
This one is?
This is left atrium, interatrial septum, and right atrium.
Okay, fine. Why are you confused? See, I am off axis view because I wanted to show the which valve?
Tricuspid valve.
Tricuspid valve, yeah. So now you change.
There is tear, ma'am.
How much is tear?
Ma'am, it's severe tear.
Yeah, when you say severe, what should be the vena contractor? That's like, you know.
I have no idea, ma'am. I have not read about this.
Here, okay.
7 millimeter.
There is another finding in the color flow. Anybody?
Am I audible, sir?
Ma'am, acquired PFO from the past BMB.
Yes.
Very
good. Very good. And Dr. Bora, and what did I measure here?
Ma'am, vena contracta.
Vena contracta. This vena contracta is here.
Tricuspid annulus.
Correct.
Yeah. Tricuspid annulus. It's quite dilated. It's 4.1 centimeter. Look at the tricuspid valve leaflets. They are structurally normal. So if during this patient, actually, whoever has assessed this patient has neglected the tricuspid valve regurgitation, patient had severe tear, which was not taken care of. So the patient has landed up with shortness of breath again. Next question.
All right.
Sir, who will answer?
Yeah, Dr. Durgesh Makwana.
Dr. Durgesh.
Give me.
Dr. Durgesh, are you there? Dr. Durgesh.
Dr. Mahapatra.
Sir, good evening.
Good evening. Go ahead, Devika.
Yes, sir.
Dr. Durgesh?
No, Dr. Resh is not. Dr. Chandan Mahapatra would answer it.
Okay, Dr. Mahapatra,
Yes, madam.
can you hear me?
Yes, yes, please.
Yeah. There is a question here. You answer the question.
What is the cause of TR, madam?
Tell me.
Mostly mitral valves, not clearly visible, but madam, it is a maybe primary tricuspid regurgitation. Mitral is not looking at clearly, madam, mitral. So I think it is a primary tricuspid regurgitation.
What is that? Primary tricuspid valve regurgitation?
Maybe due to severe pH.
Severe pH. Can you see something else which is causing the tear?
Pacing lead.
Pacing lead.
Yes, madam. There is a
Who answered this
VHG.
question?
VHG. Hello?
Okay, there is the
Sir,
pacing.
VHG.
Dr.
I think it's a
Mahapatra.
VHG. Hello?
Dr. Mahapatra has not answered the question. Someone else has answered.
VHD, madam. I tell is VHD.
It's a
Mostly
VHD.
causing. No, I
Pacing
didn't
lead.
get.
Who said pacing lead? Who said pacing lead, pacemaker?
Rahul, Dr. Rahul, ma'am.
Okay, Dr. Rahul, you are correct. Tell me, why are you telling? Can you see something? Pacemaker lead? Is it visible?
Yeah,
Rahul?
pacing lead is very visible.
Can be seen in the right atrium, ma'am.
Yes, it is visible in the right atrium. Now tell me which is the best view to visualize the pacemaker lead? In the apical chamber, not visible.
Ma'am, the RARV inflow view.
RARV, no.
Subcostal view.
Yes, subcostal view is the ideal view to visualize the pacemaker lead. Now,
Why is that? Why is that?
Why is that? Tell.
Because we can see the SVC.
Yeah, Jigna, go ahead. Why is that?
Because we can see the SVC and subcostal view from SVC. It is
One important reason is we can see the SVC. Second thing is we are imaging perpendicularly. Here we are imaging parallelly.
Yes, sir.
That is the reason, two important reason. And always we check it like from where this lead is coming. When it's come from ISVC or IVC, it comes normally with SVC only.
Yes, sir.
All right.
Yes, sir.
Now answer, anyone can pick up. What are the causes of tear in a patient with pacemaker lead?
Traumatic.
Say clearly, I can't hear you.
Traumatic.
Traumatic. Okay. Where is the trauma? Explain, tell something else.
Due to non-cooptation.
Non-cooptation. Okay. What are the causes? 1, 2, 3. Who will answer?
Perforation.
Say traumatic. Oh, okay, I agree. What type of trauma?
During procedure.
During the procedure, what?
Perforation.
Perforation, right? Okay, then next, someone has answered. The lead is sitting in the leaflet, so not, it's giving problem in cooptation. And one more cause, if someone can tell, I'll be happy.
Madam, if there will be any vegetation, infective endocarditis.
Infective endocarditis. Then without infective endocarditis, there is another cause. See, this lead may get entangled in the subvalvular area, right? the chordae may be involved, leading to the problem in movement of the leaflets. That may give rise to the tricuspid valvular. Okay, fine. Next question. Sir?
Yogesh Namdev Patil. Yogesh Namdev Patil.
I think this is the last question.
Yeah, Majrul Islam.
So I'm there.
Yogesh, go ahead. Tell simple one sentence answer for this imaging query.
I don't want detail. Tell me.
Just one answer.
Epstein anomaly.
Huh?
Epstein anomaly.
Epstein anomaly.
Okay.
It's a cell-like structure, like
yes,
very classical cell-like structure.
Cell AML is anterior leaflet of the tricuspid valve is cell-like, and look at the septal leaflet. It's apically displayed.
Ma'am, can you tell what is the exact distance for diagnosing Epstein's? Like how high up the tricuspid vault should be?
The absolute value is 20 millimeter or more. And if you take the square body surface area, that is 8
millimeter per meter body surface area.
Square body surface area.
Absolute value more than 20 millimeter and or more than 8 millimeter per square meter body surface area.
Thank you, ma'am. Thank you.
Okay, welcome. Sir, I think that's all.
Wonderful. We can stop it over here. Excellent. We done a good job, Devika. And the clips were really excellent, good collection of the cases.
Thank you, sir.
So thank you, Devika, for all your efforts. And you have done the job very beautifully, as usual, I can say that.
Yes.
And we wish Devika a big good luck. And I hope she has recovered very well.
Yes, sir.
Yes. God bless you. And you should be with us all the times. That's what I like.
There, sir.
Yeah. So guys, thank you very much. And I hope this session was very good for the people who attended. Many people, they missed the session. But those who have missed it, they'll realize only later on what they have missed today. And those who have attended, they would have realized what they have attended today. So with this few words, let me say you good night, Shabba Khair, stay safe, take care of yourself and your family. And thank you very much, Devika, again, for your excellent
Thank you, sir.
presentation. Good night. Bye-bye.
Yes, sir.
Good night, sir.
Thank you, sir.